Ken Ball with CBC. Again, I'm here on Boss Moves and Benefits with the CEO and founder of Custom Benefit Consultants, Robin.
Hello.
And joining us once again from Navitus are Jonathan Harvin and Kristin Hamilton. And on this time, we're going to be talking about specialty drugs. Uh, Top of mind for folks that sit in our chair from a consultative point of view, but likewise, more and more talk, I would say, kind of in the more the public sphere, right? Certainly from a regulatory standpoint, but we hear more and more about specialty drugs. So just backing up, so once again, we don't go down too far down the path of just jargon. What's a specialty drug, Kristen?
Specialty drug is usually defined by a cost threshold and special handling that's required. It may need to be refrigerated, may need to be kept at sub-zero temperatures, and usually has a cost of $1,000 or more. Puts it in that category.
So a quick search tells me that costs are increasing at double digits every year. The percentage of drug spend for a typical health plan is rising every single year. So, what are some effective mitigation strategies around the quickly rising costs of specialty drugs?
So there are several cost mitigation strategies. Before I get into that, it's important to note that 1 to 2% of utilization drives 50% or more of cost. We see this time and time again when we do repricing exercises. So it's a real growing problem. There's a huge pipeline of specialty drugs in the FDA, right, waiting for approval, thousands, if you will. And traditional PBMs are incentivized to push specialty drugs out the door because that's how they make money. They're making money on the units, right? So what we do is we have a really differentiated offering in that, yes, we do own a specialty drug pharmacy. However, it is actual acquisition costs. So I would put it as a more pure version of cost plus. So what we do when we dispense a claim is we tie the purchase order with which we purchase that drug to that claim. Then we add a very reasonable below market patient management fee that depends on the type of drug and handling and such, and a shipping cost. So the member and the plan receives the full benefit of purchasing on behalf of our 14 million members. So in addition to that, you actually have to, of course, support the human, right? So what we do is instead of providing a 90-day fill per se for a specialty drug, we keep it at 30. And what that allows for is actually more touch points and contacts with the member. So we're able to manage their care to better cost and most importantly, better health outcomes. So we maintain the engagement.
Now we're solving for waste. It's easy for someone to underutilized effectively, right? So if you've got a 90-day script of a drug that costs thousands of dollars per month and they're not using it all, that's flowing through to the plan. So I like that more frequent touch point, certainly.
Yep.
Kristen, I have a question for you. So on the consultant side, when we're spreadsheeting, because you said you're 2%, or 50% of the spend, that's what our clients say. Like 50% of our spend is specialty drugs. And so when we're spreadsheeting, they'll go directly to specialty and go, which PBM has the best discount, with specialty? And that's one I want to go with, right? But we all know that's a much broader question, right? So what strategies do you do and on the consulting side to be able to give the whole picture? Because a lot of times another PBM can come in with a higher discount, but we all know that if whatever discount you guys get, you're going to pass it through, right? So it could be way higher than what your guarantee is. But they might have an ability to come out of the gate with a higher discount because they have the advantage of those higher cost drugs and the rebates that are coming through the plan. So how do you explain that to a client?
No, that's an important distinction because, we're repricing and looking at claims in arrears. So we're looking at maybe 2024 claims, trying to predict the future for a 2026 plan outcome, right?
Exactly.
And so we have those educated ways of estimating, guaranteeing based on our contracts and stuff. But you said something that's really important, and that is that we're passing through full value. And that's a huge distinction for Navitus and the pass-through and transparent model is full value. We're not managing to an agreed upon discount, minus 19, minus 88, whatever the number is in a generic or brand. If we perform at minus 24, you get all 24.
Right.
And that's the very significant difference along the way, is what the spreadsheet shows and what comes in actual is very different.
Yeah, it's really hard to spreadsheet it. I mean, you can
Mhm.
you're going historical, like you said, for repricing and trying to predict, what the future is, which is pretty accurate. I'll be honest. Like Ken said, we're about 1,000. We've never been off putting our own fees at risk, but we've had to engage Milliman, and even Milliman, which we have a fantastic relationship with. They are our actuarial firm. They struggle with it too, because other PBMs will come in and say, show them another spreadsheet, and they're like, I think it's a push, and we're like, no, it's not a push. But it's interesting now that, we have a long-term relationship with them. And if they see that we're putting a transparent pharmacy and they know the other items that we're going to hit, the PAP, the couponing, the J codes, that we're going to be very aggressive about it, that they're giving us the advantage, on the premium equivalents. But it is a very difficult conversation to have.
It is. And so that's where we like to take real world data and demonstrate how did we perform. We just published our trend report for the 9th year in a row. And trend management is, again, a distinction and a differentiator where we stand on our, on our guarantees and on our reputation, where we're performing and maintaining trend below industry averages. And right there, when we can drive costs down in that first year, when a client makes the decision to move to Navitus and see double-digit savings, 17%, 25, 40% sometimes. But then we maintain that trend year over year, and they're not shooting back up to where they were when they joined us.
Yep.
And I'll just add that 30% of our clients had a negative net total cost trend in 2024.
Wow.
So, and again, just to highlight Kristin's point, I mean, you see a dip from the baseline and then it's sustained. And we have current clients who we've had for over 5 years who still haven't reached that baseline that they came from.
And I mean, that's our experience, frankly.
It is our experience.
Again, Robin mentioned it, but I often say we're batting 1,000. Each time that we've implemented this solution, it has always worked. And for the most part, these folks are not getting back to where they were previously. Not to tell tales too far out of school, but we are in a competitive situation with a healthcare coalition who was retained by the client to continue to oversee the outcome. They did not think that we could obtain the results that we were projecting. Not only did we obtain those results, but that we far exceeded them. So the other consultant from the coalition came back and literally asked us, how did you guys do that? What happened? That we were not seeing these results in any other aspect of what we're doing on a day-to-day basis. So, we've seen the results of what you guys are doing. The other thing that we've seen with what you guys are doing are strategies around biosimilars. So, for someone that may not be familiar, first of all, just with that term, and then secondly, how you are leveraging that as a strategy for cost mitigation in the specialty drug space.
So biosimilar, let's just back it up. And what is a biosimilar?
Yeah,
A
please.
generic is a drug that has been created from a chemical compound to mirror a drug, a pharmaceutical. A biosimilar, because it has a living organism, makes it more complicated to replicate. And therefore, it has some different patent life restrictions. It has different requirements from the FDA oversight. And so when a biosimilar is approved, and we're now moving into more and more in this, Humira and Stelara having biosimilars, right there, bringing them to market, there's a huge cost savings. And the efficacy that comes into play once it's approved, we want to move in that direction. We want to educate providers, or we want pharma to educate the providers. It's a joint effort here.
Right.
But we want to adopt those because we can move away and continue to drive to lowest net cost, which is what we're always focused on with the clinical efficacy as the leader.
Right. I mean, I often, given our relationship with Costco and the CBC Health Insurance Marketplace for Costco members, I often look at things through the Costco lens and one of their core values is do the right thing, right? And so to me, at first glance, that is the right thing to do. We've talked a lot about for all the things, all the levers that we have to pull, all the hoops that we have to jump through. Ultimately, we're helping people get access to care. So if we can help them get access to that very same care, the same efficacy at a lower net cost, why wouldn't we do that?
Precisely.
Exactly. And that's why we're so aligned in our mission. Costco, they're an owner, they're a client, and we share that same mission of, helping humans, bringing affordability, accessibility.
Nonetheless, we see it often, and on a prior episode, we talked about the fact that when we look at how, PBM contracts are constructed, and we can quickly deduce in about 3 questions whether or not there's a real opportunity to help people save. And one of those questions now is Humira still on your formulary? Because despite the fact that they're going to get this very nice rebate, we know with the highest degree of certainty that we can get a lower net cost via the biosimilar.
I
Absolutely.
think it's crazy that so many have them on the formulary. It's more rare that it's biosimilar first. But I think in layman's terms, what you're describing is kind of moving some of those specialty medications to a generic model, right?
Right.
And biosimilars just because it has other dynamics to that particular medication, but it's just moving it out of the specialty range too.
Well, away from brand.
Yeah.
It's still specialty, but moving away from that brand where you have that brand price tag.
Yeah.
So in as much as, the majority of our conversation has been driven around not just pharmacy benefit management, but more specifically to the pharmacy portion of a health plan. We know that a lot of specialty drugs end up living on the medical side of the health plan, right? Depending on the type of care that's being given, those are being fulfilled in doctors' offices and other sites. So what are some of the strategies that exist via the PBM, Navitus, to mitigate costs on the medical side?
Great question. And yes, it's significant. So people don't realize 30 to 40% of specialty drugs actually live on the medical side. And those are administered in hospital-owned infusion centers and home infusion centers. And they're wildly uncontrolled. If you look at the data, we have a graph that I can't show because we're on a podcast right now. But if you look at the dots, they're all over the place, the dots, right? So we have one case for, I think it's called Ocrevus, probably mispronouncing it. It's a MS drug where we were seeing cases at $90,000 that we brought down to $25,000, right? Wow. Twice a year. So the savings are there. So what we do is we take those drugs on the medical side, also known as J codes, right? And we move them to the pharmacy benefit. And then in that case, we're able to actually manage those costs and those drugs the same way we would others. So it's a great opportunity and something that's unfortunately really missed in this marketplace quite often.
So can you guys hit on the sensitivity when it is a cancer drug? I mean, I know it's a big profit center for physicians to acquire those drugs themselves and administer it in office, especially infusion therapies. And some clients are nervous about, obstructing that, and some are not. Can you kind of touch on what that's like and your recommendation there?
We tend to leave oncology alone because of the sensitivity. And so unless there's strong commitment or direction from the plan sponsor to want to carve those out, oftentimes we will keep those intact. They can be part of the formulary where they can come over to the pharmacy side, but they're not blocked. So while with the medical drugs, we have a long list where we will completely block them on the medical side, the oncology drugs are more of an option versus a mandatory.
Can you price it or do the analysis with and without oncology?
We can.
Okay, so they can make the decision. So
Yep,
if the
absolutely.
savings is there and they
Savings
feel like
is there and
doing a push for that, then that is an option. But
and most people don't want to mandate where an oncology patient is served. Site of care is a huge piece. And so if they can have, that treatment outside of a hospital in more of an infusion center, they can manage and control costs better. but they'll leave that in an optional manner versus mandatory.
But as a PBM, you can deliver that medication to those infusion sites.
Absolutely.
Correct. Yeah. So what we refer to it as, I believe, white bagging and brown bagging. So white bagging is when we send the drug to the facility. Brown bagging, which is far less frequent, is actually shipping it to the member or patient and them having taken it. Yeah. So we have some flexibility within that spectrum. But
a question, do you think that the PBMs will get involved in like the gene therapy space? So one of our clients got Zolgensma recently. It's $2 million one-time infusion right up the gut of stop loss. So, but there's no discount now.
One of my takeaways here is just really the view of Navitus as a leader in the specialty drug space in terms of cost mitigation, right? So really keying in on those mitigation strategies as it pertains to the pharmacy side, the clear opportunity that exists on the medical side. I know that Robin, there was something you wanted to add there.
No, I was just saying that, for our clients, we always want to make sure that we do the analysis for the couponing, the PAP program, and the J-code carve out. Those we have, a discounted shared savings arrangement, with our Costco value. And so, those things are really important. So you can definitely come to our site and we would be happy to do that analysis for free for you on your plan.
So as it pertains to specialty drug management, specialty drug trends, what have we missed? Or anything else that you'd add there in closing, Jonathan?
I would just add very simply that specialty is our specialty. Easy to remember, a little cheesy, but that's the truth. And we have a fully, wholeheartedly differentiated solution. You can't beat Lumicera, our cost plus, our acquisition cost plus pharmacy, and then coupled with all these other programs that we've discussed. So specialty is our specialty.
Got it. So thanks again for joining us on Boss Moves and Benefits on this episode where we discuss all things specialty drugs with the PBM pros at Navitus. Pick it up wherever you find your favorite podcast.